do? Oh, the cases went up. It's because you weren't alert enough. I know, yeah. Keep it ambiguous. Then like blame is less of an issue. So usual thing, I've picked some random cases from what you requested me to do last time, and they're all from like different modules. So there'll be a bit of randomness to it, which should keep you awake at this time, if you don't have a cup of tea like me. So here's the first case. This is a 27-year-old man. So let's just stick to the first question. What kind of things do you think cause this kind of picture? If you saw this guy in a GP setting, for example. Yeah, so in someone who's this young, who's had like this change in bowel habit and an almost significant bit of weight loss, you always want to consider inflammatory bowel disease. Okay, yeah. What else could it be? It could definitely be celiac disease as well. So that's where you have gluten intolerance. That can cause a similar problem if you continue eating gluten. What else could this be? Unlikely, but Giardia. I mean, I haven't given you his travel history. For all you know, he may well have been traveling, and he may well have got Giardia. You should always consider it with prolonged diarrhea. That's a good differential. What else could it be? Chronic pancreatitis. It could well be chronic pancreatitis. That's quite a rogue differential. What makes you think chronic pancreatitis in this case? Just chronic diarrhea. Yeah, it's good to think about. Chronic pancreatitis in someone this age, quite unlikely, but yeah, it's always good to keep in the back of your mind. What else is more common than every single thing you've said so far? Yeah, just because, IBS is definitely something you still want to be thinking about. Just because he said he was stressed because his wife was unwell and is claiming that's now okay, he might be stressed for other reasons, and IBS can occur due to a variety of different reasons. So you always want to still think about that. Colon cancer, yes, especially if he's got a family history of it, you never know. If he's got one of these hereditary syndromes. So it's good to keep everything in the back of your mind. But yeah, so you've got like this list of differentials. I'm not going to bore you with the order of investigations we're going to do today. So if you have to pick one investigation to get the diagnosis, what one investigation are you going to pick? You're only allowed one. We're running short of money. We're spending it on coronavirus instead. Colonoscopy, endoscopy with biopsy, absolutely. Definitely the investigation you're going to put your money on in this case. So this is what you see on this guy's endoscopy. What do you think is going on now? And which part of the bowel is this? Any ideas? So this is something that they could give you a picture of in your SBA. This is one of the few like things they could give you a picture of in terms of GI stuff. Yeah, so this is Crohn's disease. And Vikram, what's making you think that this is Crohn's disease opposed to something else? Cobblestone mucosa, yeah. And we'll go over the features of Crohn's disease now. But that's the important thing you're going to be looking for in terms of endoscopy. So Crohn's disease, autoinflammatory disease characterized by inflammation of all of the layers of the bowel wall, all three layers opposed to just the most superficial layer like an ulcerative colitis. We'll talk about that later as well. And importantly, this can affect any part of the GI tract. What is the most common part of the GI tract it affects there? Wait, how do you work out which part of the GI tract it is? You don't. That was just me being mean. I have no idea what part of the GI tract this is. Sorry. It's probably, I mean, so are you answering the question where it's most likely to occur, or which part of the GI tract it is? Sorry. The most, so what is the most commonly affected part of most likely to occur? Cool. Yeah. Not so surprisingly, not necessarily. So duodenum is quite likely. There is a bit of it. Yeah, terminal ileum is where it's most likely to occur. So Crohn's disease, before Dr. Crohn gave his name to it, he actually called it terminal ileitis because most of the patients he saw had inflammation in that region. But yeah, duodenum is a very common location as well, though. So presentation is a bit similar to our case here. It's an inflammatory disease, so you get your classic signs of like lethargy, fatigue. You get weight loss because it's a GI problem. Likely to get abdominal pain. Where is the pain likely to be if it's in the terminal ileum? Which quadrant? Oh, I've given you the answer there. Never mind. And yeah, you see like this change in bowel habit. It's usually diarrhea in adults. And you're looking for this, especially in people in their 20s and early 30s. That's like the age range that usually get Crohn's disease. So if we go on to investigating Crohn's, let's start with some blood tests. What blood tests would you like to run? And what result will you get? Raised CRP, ESR, absolutely. Inflammatory markers. What else? You would absolutely get anemia. You would do a full blood count to ascertain whether you'd get an anemia or not. And if you're losing the terminal ileum, what particular anemias are you at risk of? B12 deficiency, absolutely. So it's not pernicious anemia. So pernicious anemia is a cause of B12 deficiency, but in pernicious anemia, you have specific antibodies against intrinsic factor. In this case, that's not what's happening. You just don't have a functional terminal ileum. And yeah, B12 deficiency causes a megaloblastic anemia. Would you also get an anemia of chronic disease? Yeah, you could absolutely get an anemia of chronic disease as well. And if you have Crohn's that's not affecting the terminal ileum, that would be more likely. Okay, what other blood tests? There's one important blood test that we haven't talked about yet. Will you have a low iron? So depending on which part of the GI tract is affected, you could definitely have a low iron, and you could have an iron deficiency anemia as well. Calprotectin is the one I'm looking for. Clotting might go off if there's associated conditions, or if they're bleeding a lot due to the inflammation, but it's not, or they have like a bowel cancer secondary to the Crohn's, but yeah, not really. Yeah, it's not really a blood test, sorry. I just put it in here because it was a weird test. But yeah, fecal calprotectin, not in the blood. So those are the tests you want to run. You also get like this low vitamin D, which is quite important. But yeah, remember, calprotectin is in your feces, not in your blood. It's in the name. I was just waiting for someone to fall into that trap. I can't thumbs down comments. How sad. Okay, cool. And then you all said that you want to do an endoscopy. So what findings, like what SBA buzzwords are you going to look for in your endoscopy findings? Vikram's already mentioned one of them, which was cobblestoning. Skip lesions, yeah. So cobblestoning, skip lesions, kind of similar. One of these is, so both of these things are hard to see in real life, but they like to talk about them in SBA land. So rose thorn ulcers are one of them, and the other one, like, you might be able to see some fistulae or openings outside of the GI tract. But we'll talk about a better investigation for fistulae in a minute. Non-caseating granulomas on biopsy. Yeah, so my next question, which you amazingly preempted, was what are the findings on biopsy and then histology of that? So one of them is non-caseating granulomas. What else? What other significant findings? Increased goblet cells. Yeah. And the last thing I already said, it's you see inflammation and infiltration of all three layers of the bowel wall. Yeah, transmural inflammation. So while we're talking about non-caseating granulomas, what other conditions cause non-caseating granulomas? Not necessarily in the GI tract, but just around the body. Sarcoid, not tuberculosis. Tuberculosis is a caseating granuloma. What else? In the lungs, one other important thing in the lung. Histoplasmosis, that's rogue, but yeah, it does. I think that can cause non-caseating granulomas. I like that. You don't need to know that for your exams. One of the vasculitis. So GCA causes granulomas in blood vessels. Which vasculitis causes granulomas in lungs? It's in the name. Yeah, Wegener's granulomatosis and EGPA can cause it as well. Yeah, cool. Yeah. But yeah, remember TB caseating, Crohn's sarcoid non-caseating. What's this image show? So what kind of image is this? What kind of investigation is this? Yeah, this is a barium enema. It could be a swallow as well, but it's more likely to be an enema because this is the lower bowel, the large bowel. And yeah, this is showing the Cantor string sign. And what is the Cantor string sign? Someone else took control. Guys, who took control and then quit the presentation? While I reload it, Vikram is going to tell us what the Cantor string sign shows. What does anyone know what the Cantor string sign shows? What it refers to specifically? That thin bit of bowel, like a string. Yeah. What is that though? Like, what's the problem there? Like, anatomically, what's going on? That's what it refers to. Yeah. Narrow terminal ileum. Yeah. Due to what? Yeah, stricturing. That was what I was looking for. So Crohn's disease, because you've got transmural inflammation, long term you can get stricturing and narrowing of bits of the bowel. And the problem with that is you can get bowel obstruction, which is something that some of these patients can present with. So Crohn's disease is like really, really bad. Patients often report really poor quality of life. It's quite debilitating. Treatment is super important. So you can split treatment into inducing remission and maintaining remission. usually use steroids to induce remission. And if that doesn't work, you might use some of these other drugs. Everyone loves biologics. And then maintaining remission is very important. You want these people to not have their flares. You usually use azathioprine, you might use methotrexate, and it's super important that these patients stop smoking. Why do TB granulomas caseate and others don't? So caseation is where the central part of the granuloma necroses. I'm not actually sure why the TB ones caseate and the other ones don't. I did know this last year. Let me find out. It's in my notes. While I'm looking that up, what condition do you not want people to stop smoking in? Yeah, ulcerative colitis is this rogue condition where like smoking actually reduces the chance of them flaring. So anyone who's about to start treatment for ulcerative colitis, if they're smoking, you do not want them to stop smoking yet. But like in the long term, you do still want to stop them from smoking. KCA. I can't actually remember. I'll get back to you. Who asked that question? I will get back to you at the end of the lecture. But you won't need to know for your exams. What are these signs? So what's the one on the left to start with? Oh, sorry, I didn't see the messages. Yeah, so the one on the left is erythema nodosum, which is inflammation of the fat underneath your skin. And the image on the right is pyoderma gangrenosum. And why are these two relevant when we're talking about Crohn's disease and inflammatory bowel disease? They're related to autoimmune diseases. And what do we call these signs when we're talking about inflammatory bowel disease? Extra-luminal signs, extra-luminal manifestations. Yeah, that's exactly what we call them because they're outside the GI tract. And I like to split these up into those that correlate with the activity of the disease. So if you get a flare of the inflammatory bowel disease, you'll get a flare of these extra-luminal manifestations, and the ones that don't correlate with how bad or how well managed your inflammatory bowel disease is. Do you know which ones correlate with disease activity? So this is a two-step question because you need to know the other extraluminal manifestations. Erythema nodosum does correlate with disease activity. So the worse your Crohn's disease, the more likely you are to have more erythema nodosum. What else? Mouth ulcers correlate as well, but mouth ulcers aren't actually extraluminal. The mouth counts as part of the GI tract. So that's just a sign that your Crohn's is especially bad. Risk of colorectal cancer is a complication rather than a manifestation of the disease. I'm being picky, sorry, James. Anterior uveitis, not quite. That doesn't actually correlate. There's a different eye sign that does correlate, but you don't do ophthal this year, so I won't worry too much about it. So erythema nodosum and episcleritis, so inflammation of the topmost layer of the sclera, correlate with disease activity, and pauci-articular arthritis. So what that means is the arthritis you get that's similar to ankylosing spondylitis, where you get like sacroiliitis, actually corresponds to the disease activity in inflammatory bowel disease. The ones that don't correlate are polyarticular arthritis. So some patients will get like a rheumatoid arthritis-esque reaction, and that doesn't correlate with the bowel disease activity. Clubbing doesn't, pyoderma gangrenosum doesn't. Once you get inflammatory bowel disease, you tend to get clubbing that tends to stay. So it's not an indicator of how bad the bowel disease is being managed. Any questions about that? Post them in the chat anyway. Okay. What does this show? Carcinoma. Bleeding. Yes. So this is a bleeding cancer in the GI tract. This is a colorectal cancer. And this is relevant because there are several complications of Crohn's disease. You can get small increased risk of small bowel cancer, colorectal cancers, and I can't spell osteoporosis, but osteoporosis as well. So all of these are important complications that you should think about. And James was right in that, like, managing your Crohn's disease does reduce your chance of getting these cancers because inflammation directly correlates to your risk of cancer. Does anyone know why that is? Because lots of yeah, it's to do with increased rate of cell multiplication. As cells proliferate more and more quickly, you've got a higher chance of getting DNA mutations and getting these cancers. Brilliant. What's this? Another sorry, you're going to hate endoscopy by the end of this hour. No, you're not. By the end of the next 10 minutes. I've got non-bowel cases for you. Is colorectal cancer a bigger risk in UC than Crohn's? I think so. I think it is a bigger risk in ulcerative colitis. What is this endoscopy showing? Question is the chat not updating or do people not know? I'll wait 2 seconds. Cool. So it could be laxative abuse because you're thinking of what is called melanosis coli, where patients who abuse laxatives have dark pigmentation in their colon. This is actually just barn door ulcerative colitis. There is superficial inflammation of the colon. And ulcerative colitis is the other half of inflammatory bowel disease, and this time you get inflammation of just the topmost layer, which is the mucosal layer, spreads up from the rectum to the ileocecal valve. What do you get with laxative abuse? I will find a picture for you as soon as I'm done with the slide. You get this thing called melanosis coli. Let me type it. Melanosis coli. If someone wants to Googles it and puts an image in, that would be super useful. Image in the chat. And the important thing is, like, it's limited by the ileocecal valve. I don't exactly know the pathophysiology, but they can get a little bit of backwash inflammation in the terminal ileum. But yeah, it is mainly limited by this valve. Presentation, they're more likely to get bloody diarrhea, tenesmus, lower quadrant pain is what that's meant to say. And it seems to have this bimodal distribution, so you've got like younger people and like a subset of older people who are at risk of it. And yeah, this really odd thing where smoking reduces the severity. I'm not really sure how that works either. So this is ulcerative colitis. Let me find a picture of melanosis coli. I can see why you said that picture could be melanosis coli, but it does tend to be a bit darker. And what is this image showing? Yeah, this is the drain pipe colon sign. So someone with long-standing ulcerative colitis eventually loses the haustra in the large bowel. So you get like this kind of pattern. Can you see how there's no infolds into the bowel? So that's a classic sign you will see with long-standing ulcerative colitis. And then features, again, you can split them up: endoscopic, histological. You'll also get pretty much a lot of the same blood test results as last time. You get pseudopolyps in a red raw mucosa, which is the image I showed you earlier. Histology, you only see inflammatory cells in the lamina propria, and you get depletion of goblet cells. Drain pipe colon is quite a late stage sign. People who have early ulcerative colitis will not show that. Again, managing ulcerative colitis is exactly the same as Crohn's. Your approach is you induce remission and then you aim to maintain that remission. This time it's different because ulcerative colitis only affects the colon. The mainstay of treatment is these rectal salicylates, unless of course it's going all the way into the cecum or the ascending colon, and then you need to use oral aminosalicylates as well. Severe cases, severe flares, people who have like toxic megacolon, you might need IV steroids, cyclosporin, anti-TNF, or even surgery. Like this is severe ulcerative colitis is often a lot worse than like most of the cases of Crohn's you see, and a lot of these people will end up having total colectomies. Especially, and if they have a toxic megacolon, that is an indication for a colectomy. Maintain remission using whatever type of aminosalicylate, depending on where the disease is localized. And if you've got severe ulcerative colitis, or you've got 2 or more flares a year, you need to add azathioprine or mercaptopurin. I have a question for you. So with what other drug do you need to change the dose of azathioprine or mercaptopurin? If a patient is on another drug, which drug is that? So there's a very important drug we actually need to know about. And yeah, sorry. I'll repeat the question before I read out the answer, but yeah. Patients who are on another medication need a lower dose of azathioprine or mercaptopurin. What is the other medication? And the answer is allopurinol, because both of these drugs rely on the xanthine oxidase metabolism pathway. So if they're on allopurinol, you usually quarter the dose of azathioprine or use a completely different drug. For your exams, you probably need to just be like, maybe don't use azathioprine, but in real life, they would change the dose. Sorry, I worded the question badly. I just made it up on the spot. And this is a really important thing that you should know for your exams: how to tell how severe an ulcerative colitis flare is. You get all of these features depending on the severity of the flare. I just remembered the number of stools a day as the main thing, and if it's severe, they've got systemic disturbance. But yeah, this is something that does come up. Right, change of tack. Any questions about inflammatory bowel disease? We won't go into celiac or IBS today. We can do that another day. But like, learn about inflammatory bowel disease. I think it's the most important GI tract pathology in terms of exams. If you have any questions, drop them in the chat. Otherwise, tell me what this picture is showing. Facial nerve palsy. Yes, I'm glad. So one of you fell for the trick, one of you did not fall for the trick. So this is a lower motor neuron facial nerve palsy. This might be a Bell's palsy, but the Bell's palsy is it's only called a Bell's palsy if it's idiopathic. If there's a known cause, then it's just a lower motor neuron 7th. But yeah, that is what this is. And this, so Bell's sign is slightly different. So Do you know what Bell's sign? Does anyone know what Bell's sign is? So Bell's sign is where, yeah, absolutely, that's what it is. Bell's sign is when we close our eyes, the eyeball itself tends to move up and out. In Bell's palsy, when you try and close your eyes, you can't actually close your eyes, but the reflex that moves your eye still occurs. So you'll end up seeing the whites of your eyes when the patient tries and closes their eyes. But yeah, that's a useful sign. It doesn't really come up in exams. You're not really taught about it, but it's like that is a very good sign. So lower motor neuron 7th, you get paralysis of one side of the face. What is differentiating this from an upper motor neuron 7th? Yeah, it's forehead sparing. Well, an upper motor neuron one is forehead sparing, and why is that? Yeah, you have innervation, you have bilateral innervation from both hemispheres. So if you've got an upper motor neuron lesion, the other hemisphere will still be serving it, so you will still be able to move the eyebrow on the affected side. With the lower motor neuron 7th, you knock out both of them because it's after they kind of join together. So remember, that's the key difference between them. All right, and then here's something that I won't go into, but is actually quite useful. I know everyone hates like head and neck anatomy, but this is an important summary of everything you ever need to know about the facial nerve. So one of the causes of a lower motor neuron 7th is compression of the facial nerve. So, and that often happens in this facial canal. So that's why the anatomy is quite important. Okay, so next slide is what I think are the important causes, the important branches of cranial nerve 7. There's obviously other ones that other people will consider are important, but let's see how many you can guess. So give me some branches of the facial nerve. Nerve to stapedius is an important branch. What does nerve to stapedius do? It dampens down loud noises, absolutely, by causing the controlling the contraction of stapedius. Chorda tympani, also very important. What does chorda tympani do? There's one important thing it does, and then two less important things that I don't really care about. But so what is the important thing it does? Taste to the anterior 2/3 of the tongue, absolutely. Okay, you have two left. Well, one is a group. One is the petrosal, the greater petrosal nerve. What does that do? Don't worry about writing any of this down. It's all on the slides. Yeah, it innervates lacrimal gland. It innervates a lot of different glands. It's the gland nerve. And then the last one is like a group where I cheat. Yes, 5 nerves supplying facial expression. Yeah, so those are the branches I think are very useful to know. Depending on where you have an issue with your facial nerve, you'll lose some, if not all of these, or you'll have disturbance in all of these. And the 5 branches to the muscles of facial expression is why you get the paralysis of your face. All right. Causes of lower motor neuron 7th. How would you categorize these? Vikram already said one earlier because he was answering some random question. So yeah, how would you categorize these? So yeah, we spoke about idiopathic, which is Bell's palsy. Infectious causes, absolutely. So give me the 3 infectious causes of a lower motor neuron 7th that you need to know? Lyme disease. It's super. It's kind of bizarre, but yeah, it's not that rare actually. But yeah, varicella zoster. What syndrome is that? Where varicella zoster causes a lower motor neuron 7th. Ramsay-Hunt syndrome. What one other infection that you need to know as part of ENT? Yeah, so if you've got a really severe otitis media, it can spread, it can cause inflammation and compression of the facial nerve. Okay, cool. So we've done idiopathic, we've done infectious. I think those are the first two categories. Cool. What's next? Yeah, so I mean, not necessarily malignant, but any kind of tumor. And so yeah, you could have a malignant tumor, you could have a benign tumor. So any neoplastic, yeah, nice. So where can we get tumors that compress the 7th cranial nerve? Yeah, so you can have tumors within the cranium itself. So vestibular schwannoma, acoustic neuroma, those are the same thing. I always say vestibular schwannoma because it's more correct. Parotid gland, absolutely. So you need to know a number of these weird parotid gland pathologies for ENT. I can't actually remember any of them. I should probably revise that. Yeah, and cholesteatoma. Yeah, those are like probably the 3 big causes of like tumors that compress the 7th cranial nerve. And then you have all, I forgot to get an image for this, but you have all of your weird stuff. What kind of weird stuff can cause a lower motor neuron 7? Preferably without looking at the slides. Inflammatory causes, absolutely. So any vasculitis by any cause of mononeuritis multiplex. Sarcoid is actually pretty common because sarcoid commonly affects the parotid gland, and yeah, Guillain-Barré syndrome. Yeah, these are all weird things that can cause like a lower motor neuron 7th. What I haven't covered is there are several risk factors for getting like a Bell's palsy. I would have a look at those in your own time when you get a chance. Cool. But yeah, remember any cause of a mononeuritis multiplex can cause a Bell's palsy, a lower motor neuron 7th. What is the commonest cause of a mononeuritis multiplex worldwide? Diabetes mellitus, yes, absolutely. Not the exciting stuff. What is this picture showing? This is Ramsay-Hunt syndrome, characterized by what finding specifically? What is telling you that this is Ramsay-Hunt syndrome? Yeah, what about the rash? Be a bit more specific. Yeah, it's vesicles in the ear canal, which is indicative of Ramsay-Hunt syndrome. So if someone has this and they have a Bell's palsy, well, not a Bell's palsy, a lower motor neuron 7th, you have your diagnosis and you haven't done any investigations. Managing Bell's palsy, so not that interesting, but very important. You give them 1 milligram per kilogram of pred for 10 days, absolutely. And what's the other really important thing that you need to do? Eye care, so important. Yeah, these people, this is like people forget this, and it's really bad. You give them artificial tears, you tape their eyes at night. Both of these things are important. Taping their eyes at night is also important because otherwise they're going to have insomnia. They won't be able to sleep. So do not forget about eye care. Cool. Any questions about Bell's? Pop them in the chat. Last case for today. What are these 2 signs? And what are they signs? So tell me the names and then tell me what they're tests for. So the one on top is Koenig sign. Absolutely. And the one on the bottom is Brzezinski's sign. And what are both of these tests actually doing? Yeah, they test meningeal irritation, meningeal inflammation. And generally, these are the tests you do when you're suspecting a patient with meningism. So this is, I know I've definitely taught this before, but like it's so important, and so we'll revise it anyway. So what is the triad that you're looking out for in terms of meningism? What are the three things that you're going to think that might be meningitis? Fever, headache, photophobia, neck stiffness. It kind of depends who tells you. It doesn't really matter as long as you get one of those four. These are the three that I think of. But yeah, photophobia really important for meningitis. Do not forget about photophobia. And then in terms of managing meningitis, what is the first? Let's pretend you've done your A to E assessment. I hope you can all do an A to E assessment, even those of you that have missed mod A. What is the first thing you're going to do? Absolutely not an LP. The first thing you're going to do is rule out ICP. I know that people want to try and get a diagnosis quickly, but you can't risk them coning. Do you get a fever in subarachnoid hemorrhage, as in when trying to differentiate between meningitis and subarachnoid hemorrhage presentation? Yeah, so that's a really important differential to think about if you see someone who has like a meningitic picture. If anyone has that triad, don't forget about subarachnoid hemorrhage. You can actually get a fever in some people with the subarachnoid hemorrhage. So it's not actually like a definitive thing. You can actually get a fever. So I wouldn't rely on that to differentiate. Yeah, so you need to take like a really good history. Like neurology, it is the most like clinical specialty. Like neurology and rheumatology, like both of them, you need to take a really good history. You need to do a really good examination. Like your tests, okay, they might confirm something, but just if you're going to practice like one specialty's history taking skills really well, make it neurology. So yeah, we're going to do a CT head to rule out raised ICP. Some old-fashioned consultants will just check their eyes. They'll do fundoscopy, but realistically, you should still be doing a CT head. Okay, what are you going to do next? What comes after the CT head? So now you would do an LP. So that's the next thing I've got down. But there are certain situations where you wouldn't do an LP. But yeah, you would. Kajal, you would have already hopefully taken bloods during the A2E, but if not, you would definitely also take bloods. We'll talk about when you wouldn't do an LP in a minute. Okay, and then what do you do with the LP? You've sent it off for analysis. Are you just going to wait around for the results to come back? So you give them, absolutely give them dexamethasone because they're at risk of just general inflammation, and you're going to give them antibiotics. You're going to start empirical treatment, and we'll talk about what you're going to treat with in a minute. And what one other really important thing are you going to do that's not medical? Yeah, so this is a notifiable disease, so you need to tell Public Health England. You would hopefully get Senior Health as well. So Public Health England will help you do the contact tracing, so you don't need to worry about that yourself. But yeah, do not forget to alert Public Health England. Okay. So what is this image that isn't showing up? There we go. Now it's coming up. What does this image show? This is a non-blanching rash. Yep. And what kind of things could cause this rash? So absolutely, this you could get a meningococcal rash, a meningococcal septicemia. What else could cause this rash? So any severe illness causing disseminated intravascular coagulation could cause this rash, or any cause of disseminated intravascular coagulation. You'll learn that obstetrics is basically the biggest cause of DIC next year. Vasculitis can definitely cause this rash. Yeah, so remember that just because you see this, the most important thing you want to think about when you see this is meningococcal septicemia. But yeah, there is still a differential diagnosis, so don't forget about other things. Well, how does your management change when you see this rash? Antibiotics immediately and don't do an LP. You don't LP is very important. There is one thing you do before you start antibiotics, though. Yeah, you still need to do your blood cultures. So anyone comes in with this rash, do blood cultures, get an LP, and yeah, absolutely call an anesthetist. Here's the algorithm for this. This is super important. So this is like, when this happens in young babies, they lose limbs. This is super, super serious. Like, this can ruin people's lives. So do not forget that. Why do you avoid LP? Sorry. So the meningococcal septicemia, you get like this DIC-esque picture. So you're bleeding into your skin, your clotting's off. If you do an LP, they're not going to clot when you remove the needle. And because you're going into between the vertebrae, you might end up getting hematomas, things like that. So don't do an LP. They just won't clot. Does that make sense? Yeah, absolutely call an anesthetist in this case, because God knows what's going to happen. They might start bleeding into their lungs or some nonsense. Cool. Again, public health, inform them. Okay. Let me ask you a question. So you see a patient in GP and you think that they have meningitis. You don't think they have meningococcal septicemia. I mean, you're unlikely to see them if they have meningococcal septicemia, but they have meningitis. What are you going to do if you see them in a GP setting? There's two things you do. You give them intramuscular benzoyl penicillin, absolutely, and then send them to hospital. And yeah, do not delay sending them to the hospital. Yeah, that's really important. They like asking you these questions about, if you're in primary care, what would you do? So that's what you would do. And then here's an important table for your reference about how you treat people depending on what age they are. These are the empirical antibiotics you would use. For those of you that I've taught before, you will notice that the antibiotics we use have slightly changed. We now just use IV cefotaxime for everybody. You don't waste time figuring out, is it ceftriaxone or cefotaxime? Just give everyone cefotaxime. The way that no ceftriaxone ever, no. I think this is the latest guidance. I think you just use cefotaxime. This is what the BNF says now as well. Obviously, check with local guidance is always a valid answer in an OSCE scenario. The way the BNF currently splits it up is it doesn't do this till 6 years thing. It just skips out. It just does 3 to 50 years. But I put it in because the bacteria that cause meningitis do vary a little between age groups. The commonest cause of meningitis is still strep pneumoniae. The most severe cause is Neisseria. What do we use for drug guidelines then? Is PassMed good enough for exams? So PassMed has updated itself with these guidelines. So yeah, I would say try and use the most up-to-date guidance, because you can't go wrong. Then again, in your exams, they're never going to ask you about should I use ceftriaxone or cefotaxime, because we'll talk about this in a minute, but they're like the same class of cephalosporins anyway. Like, UCL doesn't expect you to have like a niche level of knowledge. What's the specific antibiotics for meningococcal and pneumococcal meningitis? I was just about to get onto that, and here's a lovely summary table for you. Exploring some of like the specific scenarios. If it's meningococcal meningitis and they have like that DIC type rash, the rash around their body, I would probably go IV cefotaxime. If it's not UK-wide empirical treatment, can they even ask about antibiotics? They can definitely ask you about whether you would use like a cephalosporin to treat a meningitis. They can definitely ask you about that. Because wherever you go in the UK, empirical treatment of meningitis will involve probably cefotaxime or ceftriaxone. They won't give those two as separate options, but they'll definitely give you one of those options and not expect you to pick it. That could be a question, if that makes sense. Is that okay? So in older people especially, meningitis can be caused by listeria. What do we tell older people to try and prevent them from getting meningitis due to listeria? We give them one simple bit of advice. Not quite avoid all cheese, but yeah, avoid certain cheeses. So what cheeses? And unpasteurized milk, absolutely. So any soft cheeses and pate, anything that like, these are the kinds of things that grow listeria. Soft cheeses, unpasteurized milk, you tell them to avoid as they get older because you don't really want them to get meningitis. So we're going to talk a little about cephalosporins. So as I said last week, I'm going to try and cover one group of antibiotics a week so you're not overwhelmed, but you have like a rough idea of what you might need to know. You get 3 generations. I think there's actually 4 generations now, but they're not going to ask you about the 4th of cephalosporins. You can tell which generation they are if you look at the letter after the F. So if there's an A after the F, it's first generation, etc., etc. Useful mnemonic auto. And they're unlikely to test you on this, but the newer ones basically have more gram-negative cover, and they're slightly worse against gram-positives. But they're still very good against gram-positives. They're just slightly worse than older generations. But what this means is that especially the 3rd generation cephalosporins are super, super broad spectrum. They're very good against a lot of gram-positive bacteria, and they're very good against a lot of gram-negative bacteria. What kind of bacteria is Neisseria meningitidis? And what is the classic finding on microscopy when you culture Neisseria meningitidis? Gram-negative diplococci. Therefore, giving them cefotaxime will cover them because it's a gram-negative cocci. Because these are very broad spectrum. What is the commonest cause of meningitis, of bacterial meningitis, that I mentioned a few slides ago? Strep pneumoniae, yeah. And what's that? What kind of bacteria is that? Gram-positive coccus, yeah. All strep are gram-positive coccus. So giving any patient with meningitis a 3rd generation cephalosporin like cefotaxime will cover them for the most severe cause of meningitis and the most common cause, which is that's the logic with giving IV cefotaxime. You've covered 2 of the most important causes. Some other useful stuff to know about cephalosporins. We use these for meningitis a lot because you need a drug that crosses the blood-brain barrier, and cephalosporins are very good at crossing that barrier. Super broad spectrum, and they're bactericidal. So if you think back to year 1, or don't think back because no one remembers it, you have bacteriostatic and bactericidal antibiotics. One will just prevent them from replicating. One of them will actually kill the ones that are there. So this one acts quick. It kills the bacteria that are infecting you at the moment. So yeah, these are the indications for cephalosporins. They're very good drugs, but they are not without their problems. So I think there are 3 big problems with cephalosporins. What do you think the problems with cephalosporins are? Allergy. So what do you mean by allergy exactly? There's a specific thing you need to know about. We'll come back to C. diff. Absolutely, C. diff is a problem. They are still beta-lactams. There is cross-sensitivity with penicillin. So someone who has an anaphylactic reaction to a penicillin-based antibiotic has a 10% chance of having an anaphylactic reaction to a cephalosporin. Okay, so 10% is the number to remember for that. Okay, so the other answers you've given are biliary sludging. So not all cephalosporins can cause biliary sludging, but some of them can. So which one in particular can cause biliary sludging? Biliary sludging is where your bile secretions get thicker, which can cause like an obstructive jaundice. Yeah, so ceftriaxone, especially in neonates or neonates that are born prematurely, can cause like biliary sludging, and use cefotaxime instead. Cefotaxime does not tend to cause biliary sludging. Use that in neonates especially. Sorry, 10% with pen allergy will be allergic to cephalosporins. Yeah, 10% of people who have an anaphylactic reaction to a penicillin will also have an anaphylactic reaction to a cephalosporin. Okay, and so I did, so yeah, biliary sludging, think about, it's kind of rare. What is the commonest, which antibiotic causes biliary, what other antibiotics cause biliary sludging? There's one other important example. Fluclox. I think Fluclox can, not the example I was looking for, but Coamox definitely can. Coamox is a very common cause of like an obstructive jaundice, which will self-resolve. I'll check Fluclox for you in a minute. I'm not sure actually. And then Izzy said you get C. difficile. What's the mechanism behind that? Why does that happen? Yeah, so it's a broad spectrum antibiotic and it wipes out your gut flora and you get this overgrowth of C. diff. So that's absolutely the mechanism by which that happens. So key things to know for cephalosporins: super broad spectrum, covered across the blood-brain barrier, and the problems you might get with them. But the one no one seemed to mention that I think is quite important is most of the patients who need cephalosporins, especially the later generations, are mainly only available in an IV form, which is a problem because you might need to admit these patients or bring them in like once a day for an IV infusion of these antibiotics. And you might think that that's not a problem, but like people have busy lives, so this is very disruptive. And also, like, you don't want to bring elderly people that into hospital because that puts them at increased risk of hospital-acquired infections. So like that is actually quite a big problem. They're great antibiotics that you can only really use in a hospital setting. Any questions about anything? I'm going to send a feedback form in the chat as per usual. If you could fill it out. Again, any comments on how you think these sessions could be more important, more useful? Other stuff you want to cover? I personally read all of the feedback after every session, so hopefully you've noticed the difference week by week, because I am trying to make these better. So all of the recordings so all of the sessions I do, I'm uploading onto my YouTube channel. So I'll post a link in the group. What's the session called? Just call it 15th May, or call it Stay Alert. Call it Stay Alert. Play into the memes. Yeah. So what are the difference between Crohn's and UC presentation-wise? So Crohn's tends to be a bit less specific, but with UC you tend to get like this bloody diarrhea type picture, but both of them you get weight loss, fatigue, lethargy, because both of them can cause anemia. But the important distinctions are what side the pain is on. Ulcerative colitis is more likely to be on the left-hand side than the right. Crohn's vice versa, and bloody diarrhea is quite a distinguishing difference between the two. How much drug management of Crohn's or UC do we need to know? It seems like sort of stuff only Reg's consultant would be in charge of. Yeah, so you would think that. Wait, I'll go back to the slide. I'm of the opinion that like most of like the stuff, management stuff that they teach you about in year 4 is like registrar level, and I'm like, surely you don't need to know that. But what I would learn is, God, I put too many animations and it takes too long to scroll through. If you can tell me, if you can in like maybe 2 lines summarize how you would induce remission and maintain remission, that's what I feel like that would be enough. Like know like the kinds of drugs you would need to induce remission and the kinds of drugs you'd need to maintain remission. I think what I put on the slides is like the very minimum you'd need to know. So like you might need to know a bit more, but like this is the absolute minimum that you do need to know for your exams. No worries. Any other questions? I'll stick around for like 5. No worries. Everyone have a nice weekend. Oh, I think me and Jake are planning to do a session on Monday, like similar format. Oh, any luck with caseating versus non-caseating? Let's have a look. I'm going to stop the recording there because no one, people don't need to know the answer to this for their exams.